Radical resection of tumor, bone, femur, or knee. The physician makes an incision overlying a tumor of the femur or knee. Adequate exposure is accomplished. Resection is performed including adjacent periosteum and muscle, a cuff of normal bone both proximal and distal to the lesion, and skin and soft tissues as necessary. For a malignant neoplasm of the femur or knee, additional bone and/or soft tissue may need to be removed, thus compromising the stability or integrity of the femur or knee joint. Separately reportable procedures, such as reconstruction of ligaments and/or tendons, reattachment of muscles, placement of donor bone graft, and use of an external fixator may be necessary as well. The incision is repaired in layers. Radical resection of tumor, clavicle, scapula. A radical resection of the clavicle bone is done due to a tumor. Either end may be resected or even the bone excised. An incision is made horizontally along the portion of the bone with the tumor to be removed. The skin and soft tissues are reflected. The acromioclavicular and/or sternoclavicular ligaments may need to be divided to free the bone from the joint at either respective end. The bone is cleared of soft tissue attachments, such as the platysma and pectoral muscles, and the diseased bone is resected with an osteotome or bone-cutting rongeurs, along with any soft tissues involved with the tumor. If the tumor is removed from one end, the remaining end of the clavicle is rounded and smoothed to eliminate the rough edge. The periosteum and soft tissues are plicated and sutured over the raw end of the clavicle. The wound is closed and a soft dressing is applied. Radical resection of tumor, proximal humerus. Removal of the proximal portion of the humerus is often performed for aggressive benign lesions and low-grade malignancies. A longitudinal incision is made from the acromioclavicular joint to the lateral border of the biceps tendon. The underlying muscles are divided to expose the bone. The joint capsule is incised and tendons are removed from the bone at the level of the proximal joint. The humerus is divided by a horizontal cut a few centimeters distal to the tumor site. A portion of the remaining medullary bone is taken for testing. The proximal portion of the bone is removed, along with any soft tissues involved with the tumor. Reconstructive alternatives following resection include reconstruction with flail shoulder, with passive spacer, with arthrodesis, and with arthroplasty. Radical resection of tumor, shaft, or distal humerus. The physician performs a radical resection of the shaft or distal humerus for a tumor. The physician makes an incision overlying the involved area of bone, dissecting down to expose the tumor site. The involved vessels and nerves are protected. Proximate muscles are detached extraperiosteally by sharp dissection, and the tumor is excised, including the immediately surrounding bone and any involved soft tissue. The wound is closed with layered sutures. Report 24151 if an autograft is necessary to replace bone removed at the tumor site. The physician harvests the graft, usually from the patient's iliac crest, with an osteotome. The physician closes the surgically created graft donor site. The bone is placed in the recipient area of the humerus. The bone graft may need to be stabilized with screws or wires. Suction drains are inserted into the wound. The physician repairs the incision in layers. Radical resection of tumor, radial head, or neck. The physician performs a radical resection of the radial head or neck for a tumor. The physician makes an anterolateral incision overlying the elbow or forearm. Dissection exposes the radial head or neck. The radial vessels and nerve are protected. The tumor is excised, including the radial head or neck. The physician selects the level of the radius to be divided. The physician uses a bone saw to divide the bone at the appropriate level. The muscles are detached by sharp dissection. Radical resection may also include removal of surrounding soft tissues such as muscles, fascia, and vessels. Radical resection for tumor, radius, or ulna. The physician performs a radical resection of the radius or ulna for a tumor. The physician makes a skin incision along the lateral, anterior, or dorsal aspect of the forearm, depending on the area of resection. Resection of the proximal ulna is described. The physician makes a longitudinal posterior incision, dissecting down to expose the tumor site. The triceps insertion is detached from the ulna. The physician uses a bone saw to make an osteotomy cut in the ulna and the tumor is excised, including the immediate surrounding bone and any involved soft tissue. If much of the proximal ulna is removed, the radius may be dislocated posteriorly so that the radial neck articulates with the trochlea and the triceps tendon is sutured to the radial head. Drains are inserted and the incision is repaired in layers. A posterior splint is applied. No bone graft is used. Radical resection of tumor or infection, wing of ilium, 1 pubic or ischial ramus or symphysis pubis. The patient is positioned for a lithotomy with the buttock elevated. For resection, excision, of the pubis and/or ischium, an incision is made from the pubic tubercle to the ischial tuberosity. The adductor and obturator muscles are detached from the pubis and ischium. Additional dissection is carried down to better expose the pubis and ischium. The remaining muscles and ligaments are released, freed by incision, while the pudendal and genital nerves and vessels are protected. The bone, is separated and cut with bone-cutting forceps and an osteotome or saw. The bone segments are removed. A separate incision is made to resect the ilium. As above, the portion of the ilium needing resection is dissected out by releasing muscles, tendons, and ligaments. The incisions are repaired in layers. Radical resection of tumor or infection, ilium, including acetabulum, both pubic rami or ischium and acetabulum. The patient is placed in a lateral decubitus, lying on the side, position. The physician makes an incision from the posterior crest of the ilium to the symphysis pubis. A vertical extension of this incision is made, extending into the proximal thigh. The physician carries dissection down, while protecting the femoral artery, vein, and nerve. The physician uses a saw to divide, separate, the ilium and the pubic bone. Any remaining soft tissue is released, freed by incision, from the segment of bone to be removed. The inguinal ligament is reattached to the iliopsoas tendon to prevent a hernia. The incision is repaired in layers over a suction drain. Radical resection of tumor or infection, innominate bone, total. The patient is placed in a supine position with the involved side elevated. The physician makes an incision extending from the postero-superior iliac spine, along the iliac crest, to the symphysis pubis. A vertical incision is made extending into the upper thigh. The abdominal muscles are detached. All muscles that attach to the innominate bone are divided and detached. Vessels and nerves are also separated and/or ligated. The hip joint capsule is incised. The sacroiliac joint is exposed and divided with an osteotome. The innominate bone is removed. The incision is repaired in layers. Radical resection of tumor or infection, ischial tuberosity and greater trochanter of femur. The patient is positioned prone to access the ischial tuberosity in a lateral decubitus position to access the greater trochanter. The physician makes an incision overlying the involved bone and dissects through the deep layers. The ischial tuberosity or greater trochanter is exposed and resected. The wound is closed in layers with sutures. Radical resection of tumor, tarsal, except talus or calcaneus. Metatarsal. Phalanx of toe. Radical removal of a tumor involves complete removal of the affected tarsal bone, including the navicular, cuboid, or any of the three cuneiform bones, and the soft tissues that surround it. This is performed in order to prevent spreading of the tumor to adjacent tissues. If it is determined that the foot is going to be spared from amputation, the affected bone and soft tissues would be removed through a dorsal incision at the front of the ankle. The skin and tendons are reflected and the bone is identified. The capsule is released and the bone is removed in one piece. Tissue samples are taken to determine the extent of tumor growth and need of soft tissue removal. Once complete, the wound is closed with sutures and dressing and cast are applied. Radical resection of tumor, tibia, fibula, talus or calcaneus. The physician removes a tumor with radical resection. The physician incises the overlying skin and dissects to the bone, freeing the involved bone from muscular attachments and the tissue bed. The area affected by tumor is removed, and the wound is sutured in layers. Radical resection, metacarpal, e.g., tumor. Proximal or middle phalanx of finger, e.g., tumor. Distal phalanx of finger, e.g., tumor. The physician radically resects a bone, e.g., for a tumor. The physician incises the overlying skin and dissects to determine the extent of invasion. The bone and surrounding tissues are resected. If a graft is needed for reconstruction, it is obtained from the distal radius or iliac crest. Skin is approximated over the remaining digit and sutured in layers. Resection humeral head. The physician performs a resection of the humeral head. An incision is made over the joint in the upper arm and the underlying muscles are divided to expose the bone. The joint capsule is incised and tendons are removed from the bone. The physician makes a horizontal cut through the humerus just distal to the head and removes the bone. Separately reportable hemiarthroplasty to replace the proximal humeral bone with an implant for attaching the tendons and reconstructing the joint usually follows. Radical resection of sternum. With mediastinal lymphadenectomy. The physician removes most or all of the sternum from the chest. With the patient under anesthesia, the physician makes a long incision overlying the sternum and anterior chest. This is carried deep to the bone. Dissection is performed around the sternum. Ribs are disarticulated as needed and thorough debridement is accomplished. Using saws and other surgical instruments, the physician removes the bone. Internal fixation devices, reported separately, are often needed to support the ribs and chest wall. The wound is irrigated and closed in layers. Report 21632 if a mediastinal lymphadenectomy is performed during the procedure. Radical resection of capsule, soft tissue, and heterotopic bone, elbow, with contracture release. The physician radically resects the elbow joint capsule, undesirable soft tissue and bone, and releases a contracture of a muscle or tendon. With the patient under anesthesia, the physician makes a long longitudinal incision overlying the elbow. Depending on the extent of the excess bone to be removed or the severity of the contracture, additional incisions may be required. The incision is continued deep to the elbow joint capsule itself. nerves, vessels, and tendons are retracted. The capsule is fully exposed. A thorough debridement is undertaken to excise unwanted soft tissue. The overgrown and excess bone is isolated and excised. The capsule is resected. The contracture of the elbow involving muscle, tendon, scar tissue, or soft tissue is identified and explored. The physician releases the offending tissue to allow full elbow range of motion. The wound or wounds are irrigated and closed in layers. A dressing is applied. Radical resection of tonsil, tonsillar pillars, and slash or retromolar trigone, without closure. Closure with local flap, e.g., tongue, buccal. Closure with other flap. The physician removes the tonsils, tonsillar pillars, and slash or the retromolar trigone, along with any affected area of the maxilla or mandible involved in the tumor. First, the physician performs a tracheostomy. The involved tissue is resected. In addition to the above areas, radical resection may include a hemoglossectomy or a total glossectomy, as well as a full neck dissection. In 42842, the wound is so extensive that it is packed open and grafted at a later session. In 42844, the wound is less extensive and can be closed primarily with sutured layers. In 42845, a flap is rotated from the chest. If the wound included a resection of the mandible or maxilla, a fibular bone graft or a metal plate may be used to reconstruct the jaw. Radical excision of bursa, synovia of wrist, or forearm tendon sheaths, e.g., tenosynovitis, fungus, TBC, or other granulomas, rheumatoid arthritis, flexors. Extensors, with or without transposition of dorsal retinaculum. Radical excision is removal of all diseased and slash or inflamed tissue and may include removal of a portion of surrounding normal tissue. The physician makes a longitudinal incision over the volar aspect of the distal forearm and wrist. Dissection exposes the flexor tendons of the wrist. The physician excises the bursa and any inflamed and hypertrophied tissues from around the tendons. The tendons are left intact, allowing them to glide better during wrist movement. In 25116, the physician may perform a transposition of the dorsal retinaculum if enough tissue is removed from the wrist extensors. A transposition makes a smooth gliding surface no longer present between the extensor tendons and carpal bones of the wrist. The dorsal retinaculum is incised in the midline, tucked underneath the extensor tendons, and closed with sutures. The incisions are repaired in layers with sutures, staples, and slash or stri strips. The wrist may be placed in a splint.